But yeah, to your point, it's some communities pay for Wi-Fi or pay for food on the table, and it's a very different scenario.
Yeah, and it's exactly it. Some communities have both. Some communities, desperation is part of the world that they live in.
Yeah. Let's see. We've got all right, our attendees. And, go ahead and start in just a couple of minutes. Let most people join or come from their previous meetings. Turn that off.
It's a beautiful painting you have behind you, Scott. Is it from the Orient? Is it from Asia?
No, it's from an artist back east. I can't remember her name. My wife picked it out. I do like it. And I was actually just funny. I was admiring your watercolor in your background.
We're wearing window pane jackets. We both have coffee and a drink near us. Pocket square, beautiful paintings behind us. This is going to be like-minded individuals exchanging.
It's going to be great. It's going to be fantastic.
I'm looking forward to this. And to the people who are popping in now, I welcome them all.
Absolutely. Okay. Another minute, and we'll go ahead and get started. I think people will kind of continue to trickle in. Tom Jones says there's a role for art in healthcare. Yes, Tom. Yes,
Tom is a dear colleague of mine. He is a champion for health and wellness, headquartered in our New York office, and actually he is very dedicated to the arts in Morris, the Morris Arts Museum. I probably got the name wrong, but Tom actually is one of the catalysts for an annual gathering of people who love the arts. Finn is a proud supporter of that gathering, and it's actually due to Tom's advocacy. It's fascinating that art is really the foundation of society. So I'm glad we both have art behind us, Scott. We're standing on a good foundation.
That's fantastic. Thanks, Tom. Thanks for all you do. And Brandon, yes, we will be sharing a recording of today's event. We will be making that available on Friday. Part of that is due to give us a chance to evaluate any additional questions at the end that we may not have been able to get to. And we will post the answers to those questions in conjunction with the recording. And it's Morris Arts Council for Northern New Jersey. Thanks, Tom.
We should have really tapped into Tom's connections to spruce up our artwork for this program.
Hey, we can do it afterwards, and then we can make another one of these, Gil.
That's true. Look up a Rembrandt, a Picasso behind you and me always sort of adds to the quality of the conversation. Now we're going to put Tom
those low budget pieces. Those low budget pieces, huh? Yeah. All right. Let's go ahead and get started. Thank you all. I appreciate everyone joining and participating today. My name is Scott Bangeter. I'm with OSP, and welcome to our webinar, which is Bridging the Gap with Digital Innovation. Today, and we're going to talk with Gil Bashe about that gap in digital health innovation. And annually, the U.S. invests heavily into healthcare, both the industry and into healthcare related technology. Yet we see that many patients end up with limited access or are actually deprived of healthcare access outright. And it's funny because Gil and I were just talking about this before this meeting started. Now, additionally, inefficiencies exist and they create choke points in the system. Despite having set appointments, patients present at the clinic, but end up having extended wait times before seeing their provider. Some of these inefficiencies can be attributed to complex regulatory system, whether that be HIPAA, PHI, or other legislated norms. These deficiencies also create a gap between patients and their providers. And in turn, the gap can result in a communications breakdown, which is becoming a growing concern for the healthcare industry as a whole. Patient-provider communication is essential because ultimately it can determine the success or failure of healthcare outcomes. Today, we're going to explore whether technology developments can bridge the gap. For some of you, in our previous webinar with Stacy Hurt, we spoke about considering patient opinions and their significance. Today, we're happy to have Gil Bashe, a HIMSS 20 digital influencer, author, rabbi, and ambassador for healthcare communications, to talk to us about the need to simplify patient-provider communication and the need to eliminate or reduce communication gaps. New digital health innovations are constantly introduced to meet the growing needs and transitions in our healthcare industry. How can digital health technology provide instant real-time communication with providers? Well, we're going to find that out today. So let's hear Gil's thoughts and see if we can facilitate change. So thanks, Gil. Appreciate you being here.
Scott and OSP, thank you very much for having me. That's a sort of a great kickoff to an important conversation. I was reflecting during your introductory words, Scott, that we really live in a society of dichotomy. I can order a pizza using my cell phone, but I can't make a doctor's appointment. We're so used to being able to channel our needs and interests through technology. And yet the system of which our lives depend upon, rest upon, actually doesn't seem to work for us as customers of the system. The system is in fact its own customer, and we're external to the system. So I hope we get into the issues today. We talk a little bit about technology, health technology, how it can be a bridge to that. And we also take a look at the fact that, at some point or another, we will all be patients. I think that while we're blessed to have health, we tend to forget that there are people who don't, and we won't. And the conversation we're having today, thanks to you and OSP, actually sets the tone for what the future could look like to benefit all of us. So I'm going to turn this back to you, Scott. I know that you've been diligently putting together a long list of questions. Some comfortable, some designed to make me squirm. Let's bring it on.
Absolutely. Thanks, Gil. So I think we can both agree that at least over the past 10, 15 years, healthcare has been undergoing major transformations. Some of it organic and others forced, both due to most recently pandemic and others due to the nature of healthcare delivery. One of the most common concerns has been ensuring on-time and real-time care access to our patients. Can you maybe narrate for us what you think or some common hurdles that patients struggle with relating to real-time access?
Yeah, first of all, it's fascinating. Just last week, very recently, April 5th it was, so it's I guess 2 weeks ago, the Cures Act information blocking clause came into effect. And I think it's sort of like, that's a law, it's a regulation. Did anybody pay attention? Does anybody care? And what that ruling essentially guides us is that you and I, our listeners today, are entitled to their health information. In many cases, down to the notes doctors write by hand in their patient interviews. You and I are entitled to that information. It's our information. And yet, let's face it, do we really think that's happening right now, 2 weeks after the rule went into effect? Do we really think that doctors aren't going to ask us whether we have a fax machine or not in order to send documents back and forth? I think this is a big opportunity that's gone out with a pop. And so it starts with a basic premise. Who are you? I mean, I understand that we're people, always people first and patients second, but we're supposedly customers of the system. You reflect on this patient centricity, but Does that mean customer centricity? No, it doesn't. So I think some of the obstacles we're facing, to answer your question, are the health providers' fear of law, whether HIPAA is working for us as consumers or against us as consumers. I believe that HIPAA was created, it was designed to protect our privacy. And now, unfortunately, it's flipped the other way, where it's actually protecting us from us. And it's designed really to protect the system, from the legal system of saying your information went out there. Cybersecurity is an issue that blocks us from really having a much more transparent, inclusive system. Hospitals use the fax machine because it's a very secure system. You can't breach and grab a fax as it's being transmitted through your phone line, can you? But you can breach an email system. You can breach a mainframe system. So that's working against us as well. And then aside from this core issue, we have a problem that in reality, I'm not certain that our system thinks of patients as actually customers, equal partners in the fragmented health ecosystem. So when the system thinks of the system, it thinks of providers, it thinks of policymakers, it thinks of payers, it may think of product innovation or products, but how about the organization centering around the very person it seeks to help and heal? People with health concerns, called patients for short. Always people, patients when they're interfacing the system. I think the inherent challenge isn't lack of ideas or innovation, Scott. I think the inherent challenge is clarity of who are we doing this for? We're doing it for us as people, us as patients. And until we get that clear, we're never going to align all of these pieces in a way that accelerates access to care and actually improves people's lives.
So to that point, what I hear you saying, Gil, we're rules, regulations, policy is handcuffing, patients to be almost hit with their personal health information. It's become a weapon against them versus something that assists them through the process to gain access to care. Do and will new innovations in the healthcare sector and within the technology sector help overcome that, or is that creating a two-edged sword, or accentuating the two-edged sword that patients are currently dealing with?
Well, look, I think that the more it's a question, part A, part B. Let me deal with part A first. Part A deals with your question specifically, will technology accelerate our access to information and our sharing of information? The quick answer to that is yes, it will. The more innovation we create and the more innovation is supported, the more access we will have, the faster decision-making we can come to. So I'm wearing my Apple Watch 6. I have down below here my Apple iPhone 12 Pro. They're aligned, they're connected. I can connect those to my doctor. In many cases, you can connect them to, in some cases, electronic medical record systems to update the use of apps on the phone. So that's where technology is actually streamlining our system. But it's a one-way approach, isn't it? I'm feeding in my data to the system. I'm sharing it with my doctor. I've seen some wonderful things, Scott, recently. I was sitting with folks who are in charge of digital health at companies like Teva and Sanofi. The folks at Teva were showing me a magnificent asthma care system where the device, which they call the propeller, you breathe into, it connects actually to your iPhone to see what your respiratory, your lung function is, like peak flow, and that in turn goes over to your doctor. That's a great example of greater connectivity. Or Sanofi, which is very much involved in diabetes, is looking at digital health management, where they're helping to connect your blood glucose meter, your insulin pump, your adjustments of such based on your your diet and so forth, and giving you and your doctor advice of how to adjust your insulin. That's a great example where technology is improving care. But it's one way. It rests upon one, the consumer, the person, the patient, having those tools, having the wherewithal to get those tools. Economically, having the insurance plan that supports those tools. So that gives me question part B to your question. We have great innovation coming forward, but the challenge we have is reimbursement for that innovation. So a lot of that innovation is approved by the Food and Drug Administration as what's called a 510K. Means it's a medical device, effectively. And they review it. It needs a good clinical study. They review it. They approve it for market. It's approved. It can be sold. Problem, needs to get onto a formulary. Payers more often than not reject digital health devices or medical devices that use digital technologies, and they use a term called investigational. Investigational. That's a problem because the FDA has determined, basis of its review, that it's not investigational. It's approved for an indication of use. The payer pushes back and says, no. I see cases, a great example, people who suffer from migraines. Migraines can be debilitating. I see cases where the Veterans Administration has approved for use a migraine device that uses a neurotransmitter for America's toughest, our veterans who deserve great care. But yet the device is also approved for pediatric use. They can't get access. So yes, we have technology that improves care and connects us. Problem, we need to align interests of the system. The interests of the system don't always align to the needs of the patient. That's a problem, Scott, needs to be addressed.
I couldn't agree more. And with that in mind, yes, creating better access, but on the flip side of that, over here, patient communication and the ability, I think you alluded to this earlier with your Apple Watch, your iPhone, you're providing information out, and albeit, remove demographics from that conversation, but patient communication out to the provider, there's still gaps, there's still delays on the return side of it, to where, how does that information become actionable? And again, how does it become more patient centric, if you will?
Yeah. So I'm happy to say that we're graduating a generation of young clinicians. First of all, everybody who gets into medicine, you and me, and I know Stacy Hurd is listening in. She was on the program just a few weeks ago. She actually comes from the healthcare profession. She is a magnificent patient advocate. I'm honored that Stacy is listening in today. It's a privilege for me to have her presence. But the challenge is we have a generation of younger physicians who have always known connected technology. They've always known Wi-Fi. They've always known Bluetooth. We have an older generation that obviously is in authority that really relied on the traditional form of medicine, which was retained knowledge. So the purpose of grand rounds, if we go back into the hospital system, and you and I and others on this call wander the hospital system frequently. I certainly started some of my career in the hospital system. The great clinicians retained information, and they would share, like Plato, their knowledge to their residents as they walked the halls and they looked at patient charts. And the clinician, the great clinician, tested them, much the Socratic method of medicine. But now it's a question of, do you need to retain all that information, or do you need to know how to access systems that can give you that information? And so you see the tension that exists. And a lot of the young clinicians today who are really at the cutting edge of medicine are combining both their clinical knowledge and their technical knowledge. Interestingly enough, when I speak with those people, and some of them are actually in the health information side or technology, John White of WebMD is a physician. He still treats patients. He's chief medical officer of WebMD. He's a big technologist as well. you see their comfort of going back and forth and being very patient-centric. Why? They're connected intuitively. They're using smart technology to speak with other people, to speak with their patients. They're not frightened of sending texts and emails, all of that. But you find that what we'll call the technical literacy of the clinician also influences their desire to use technology to connect to their patients. They're also concerned at the same time, like email, HIPAA. How many doctors do we know are comfortable emailing their patients back and forth? They're not, because they're frightened of cybersecurity. So we have a basic break in the system. For those people who are listening in, who are active patient caregivers, or in the cycle of their lives where they're active patients, if they want to add to the chat, they're welcome to. But the reality is, it's tough to get information out of your physician. You've got to schedule an appointment, a telehealth visit. It's not spontaneous. And anxiety as a patient is an anxious moment. Our system isn't working to actually address the emotional psychodynamic needs of the patient. And I think that in this COVID period, it's very important that we look at how COVID actually brought the obstacles down, brought the walls down. The Emergency Act of FDA approvals for digital health technologies, telehealth, pushing through vaccines, pushing through diagnostics, albeit not a perfect system, showed us, gee, we don't need 10 years to approve a product. How strange. What about cancer? What about diabetes? Do we need to wait 10 years to approve a product? I don't know. It's a good question. How about use of digital health technologies? Do we need to wait forever to use them? I don't think so.
And you bring up, I mean, what a wonderful segue. If you take a look at, what are we going on, 14 months now since the pandemic settled in and we all adjusted to the new normal, and how quickly we saw medicine and healthcare delivery pivot. Almost, it felt like it happened almost overnight relative to those of us who have been in and around healthcare for almost 20 years. It's been a very slow plodding along typically, and then the pandemic happened and it showed what was technically very capable of happening in healthcare delivery. Now, a lot of that, I have to believe, was due to where we are from a technology standpoint culturally. Certain levels of adoption, both the patient side as well as the acute care environment. But, to take your point a little bit further, will we see this stay? We're already seeing some trends that adoption levels of digital health technology are stabilizing versus accelerating. Where do you see us going next relative to the heavy adoption levels we saw a year ago?
Scott, you're spot on. The reality is it's all about money. It's all about the economics. Health providers do want to heal. There's no doubt about that. They're passionate about that. And I often find that the system itself can wear some of them down. The system that deals with economics, bureaucracy, who gets paid, a reality I have. I go see doctors both to take care of myself preventively, but to learn. And so when you see a primary care physician, a GPFP, they might bill. They have to bill you for the pulse ox moment. They bill you to check your heart. They bill you to have a conversation. The technician actually has a code that bills you for taking your weight and temperature. All of those little things are billable moments in the life cycle of your visit to your GPFP. They'll bill you all in all $125. They'll bill out to the payer, and they may get back $36 as the normal customary fee for the doctor seeing you for that 7-minute clip. And you're being there, forget about the waiting room. That's another issue altogether. But being in the examination room for 22 minutes between the wait, and the conversation. How do you sustain a system like that for a doctor? Who wants to be a doctor where you've got to figure out how to bill for every little button in medicine? So that's a really big problem in our system. And the reason it's slipping back, let's say telehealth. Right now, we have essentially 51 health systems in this country. I want to emphasize that again. We have 51 health systems in this country. And that means that the health system or the Commission of Health of Illinois and the Commission of Health of Texas don't necessarily have to see eye to eye on telehealth. Part of the laws or regulations that are created are to protect the citizens of that state economically. So I'll give you an example. True story, I won't mention names. A case I know of a young woman with a rare cancer would like to speak to, she's in one state, she'd like to speak to a physician at MD Anderson who's a world-class expert on that cancer. He too would like to speak with her to help her. Problem, her call, her telehealth call between her state and Texas can happen. Why? Her state doesn't recognize out-of-state telehealth calls. So the doctor who's never met her physically can have a telehealth visit because he's never had a physical examination visit with a patient, the patient. And so she cannot get the direct counsel from this world-class expert who does want to help her. Why? The system, the policies of the system are working against them. Why? One state feels it's protecting the economics of its physicians in its state. So what's going to happen post-pandemic is while telehealth and other elements have stabilized, and I do believe telehealth is here to stay, it's not here to stay at the levels we've enjoyed it so far. That's a problem. In some countries that I deal with around the world, if you get up because your child is coughing and you think it's the croup in the middle of the night, and you call into your health system, in 15 minutes, you're on the phone with a physician. Why? Telehealth, national telehealth. It's a given. You punch in what the concerns are, a on-call pediatrician for that slot or a nurse practitioner or physician's assistant is on the phone with you within 15 minutes. But we have a situation, and I'll pivot to where technology could be most vital. Developing, you touched on this, developing new therapies. Well, our whole clinical trial system is based on where you live. You've got to live near a site that's holding that trial. If you have a rare disease and the trial site's in Chicago or Los Angeles or Salt Lake City where you are, guess what? And you live in Nebraska, either you move your family to one of those sites or you die. That's not a solution, is it? That's not patient-centric. And Scott, I'm going to put my foot down. It's not acceptable in a nation as great as this, with the amount of innovation and ideas we have, that someone has to make that choice. Decentralized clinical trials will not only democratize clinical trials, they will make it possible for people who live in remote locations to use technology like telehealth that you just mentioned and other connected technologies to participate in the drug innovation system.
And another point to that, just to, cable on to that, a lot of people don't realize that within the clinical trial world, because of their locales, quite frequently, they're unable to advance the size of the cohorts that they need to complete the clinical trial in a timely fashion. I have a few friends who are in that world, and quite often they just don't get sufficient respondents in a given market. And if you democratize it, much like you're talking about, the advancements and the acceleration of healthcare technology would only better the healthcare system as a whole. So
you're right. I mean, you said it. Look, part of it is filling up trials. And actually, in terms of the quality of the trial, the sooner we do it with the right patients, the better off we are. The more we have to sort of say we need to add more sites, the more we diminish the quality of the trial. So you just hit on a really important point, which is technology, our embracing technology, making it part of the system, getting the regulatory, the policy process to embrace technology. That's great. There's a great organization that's been founded. I recommend people visit it. It's called DTRA.org, Decentralized Trials Research Alliance. It comprises 100 entities, both regulatory, patient organizations, major pharmaceutical companies, and clinical research organizations are uniting to actually look at making trials more democratic? So you're right on by asking that question. And I know that you and OSP are real champions for ensuring that systems have a smooth flow of information.
Well, thank you. And I'm going to actually ask you to plug a few more. I think from your particular standpoint, as well as the ways in which you are engaging both the healthcare community, policymakers, legislators, you know, are there some applications that you could reference or even recommend that you see that are advancing what we're talking about today, or at least making the process easier?
Yeah. So first of all, I guess they call it hat tips to people. Well, I think Dr. Amy Abernathy, who is the principal deputy commissioner at the Food and Drug Administration, she's leaving her post at the end of this month. She really was a welcomed breath of fresh air within the Food and Drug Administration, trying to bring down some of these hurdles. I think that her presence at the agency will A, be missed, but B, I don't think that they're going to move away from her vantage points. She was really looking at bringing more digital technology into the agency. Now, why is this important, Scott? It's so important because when we think of therapeutics, whether it be pills or biologics or medical devices, we're headed toward the connected world. There's no doubt about it that technologies can tell us things like, is it safe to take that medication with this other medication? Did you take the medication? Do you understand why you're taking the medication? Do you need to let your doctor know you're experiencing something from the medication? Technologies do all that. And I think that some of the entities that I look at very closely, where a lot of these conversations are happening, certainly you mentioned HIMSS at the beginning of the conversation. HIMSS is an important organization. There's another organization that's related to HIMSS I follow very closely called HITMIC, the Health Information Technology Marketing Community. Very important community for people listening in to this call and listening to the video. That's an important group. A meeting I go to every year, it stands for Collaboration for Novel Solutions, called CNS Summit. It will be meeting the week of, I think, November 7th in Boston. It's a great meeting for anybody interested in health, collaboration, novel solutions, and actually not looking at building barriers, but tearing them down. That's another forum. So those are three forums I really think are really wonderful places. I also, by the way, want to give a call out to you and your colleagues at OSP. I think your webinar series, that people should subscribe to the webinar series, look at the speakers. These are, I'll put myself aside, but the speakers you have are world-class. OSP is providing a great service to the entire health industry. And I have to say, as someone passionate about this industry, I have to thank you and your colleagues for making that possible.
Thank you. I appreciate that very much. I'm fortunate to be surrounded by a number of extremely talented individuals, as well as both from our client standpoint, as well as internally at OSP. So advancing technology to solve a number of the problems and challenges that we're talking about today, I get to participate that in every day of my week. So I'm lucky there.
Yeah. Todd, Scott, rather, if I could add a point to something we've talked about a moment ago, which is reimbursement. Is it all right if I do that?
I think it fits. It's an important component here because it directly correlates to whether or not an aspect of healthcare adopts technology or doesn't adopt technology.
Bingo. So one of the things that I've been concerned about is the transparency of our system. We don't know how much things cost. I mean, certainly when you and your family go out to buy a new car, it's also a bit of a mystery, isn't it? When you go to the car dealership, you see the sticker price, you've looked at the blue book, you've done some research, and you see this price on the car, and suddenly you're negotiating for the actual cost you want to pay. And if you're going to lease it or purchase it, with a loan, you're negotiating monthly payments. It's kind of mysterious. Accessing the health system is like buying a new car. Huh? And we have no idea of like how much a hip replacement costs from this hospital to the next hospital. We have no idea of how the system sort of works. One doctor does something to you, another doctor looks in on you, and then another person discharges you. It's a wacko system. Reimbursement is driving decisions. Who gets paid for what, when? And what is normal customary payment for who and what and when also. So I just want to go back to our core theme, which is technology. I think a lot of amazing inventors do champion technologies, some of which we've talked about, some we haven't, like artificial intelligence, virtual reality. These are important elements of technology we should explore at some point. But when I look at what we really think of as technology, which is kind of implantables, wearables, wireless technologies, all of those technologies have a hurdle. Their inventors invent them, and then they come up to the harsh reality of the system. How do I get reimbursed for it, and how do I integrate it into the system? And who's the buyer? Is it the chief information officer at the hospital system at Northwell or Cedars-Sinai or another major center? Is it the chair of the Department of Cardiology? Is it the chief of nursing? Is it the chief financial officer? Who's the conduit for technology within the health system itself, the provider system? It's kind of mysterious from system to system. And then what we don't realize is these technologies need a code, a J code, or they're covered under the umbrella cost of the DRGs, for that procedure. And a lot of our inventors out there of amazing health technologies, unfortunately, no one gave them a course in health economics. And that's a challenge for them. They come up to the harsh reality of our system. And so generally, if you're from the technology side listening into our conversation today, I highly recommend connect to an incubator. Even if you have great funding, either hire a great group that knows health reimbursement, hire a group like OSP that can help you understand the system from an information standpoint, or get a consultant. Because if you don't understand how to secure reimbursement, I think FDA approval to market is the easy bar to cross if you've got great data. Getting into the system is the hurdle, is the wall you've got to scale.
Absolutely. And it's unfortunate. I mean, in my position with OSP, the number of times that I have begun discussions with an organization that seems to have a fantastic offering to market that solves real problems within a number of months ends up dying on the vine because they just can't penetrate the market in a particular way, or their particular solve runs up against so many rules and regulations, and how do you survive long enough to overcome? But those recommendations that you gave, talking about incubator, talking about a consultant, I think those are fantastic recommendations for anybody on the technology side looking to figure out, how to penetrate the system. And with the big S that you and I have alluded to over and over again in this conversation. One area I'd like to get back to, in talking about, access to care and communication, I think you alluded to it, I've mentioned it, a patient comes in, needs to see their provider, ends up sitting an hour and a half before they even get into their visit, and then potentially even sits an hour afterwards waiting possibly to take some labs. And a lot of this has to do with the inability of creating a proper information exchange, both prior to the visit and afterwards. OSP has had the benefit of working with a couple of organizations that are trying to solve this by, basically a pre-visit online submission of information, filling out, but yet they have themselves, it's still not quite breaking through. So can we talk about virtual care and maybe where you see improvements in the process that we can make access easier just through simplified communication? Does that make sense?
Yeah, totally makes sense. Let's I think both agree. Wouldn't we agree that we do have sort of the potential of a great health system in this country, right? Right. We
Yes.
have a great health. So let me ask you, I'm going to say this facetiously. I think the clipboard industry would object to your suggestion of we make it easier. How many times have you gone to a doctor, Scott, and when you arrived, they gave you a clipboard and a pen? Do you have enough fingers and toes to count those moments?
No, I mean, I
No.
would have to imagine that the healthcare system is keeping the clipboard industry in business.
Totally, totally. So it's amazing. We're talking about technology that's based on a clipboard. I mean, think about that. It's absurd. I will just to I'm blessed to have gotten both of my vaccines. I got my vaccines at a supermarket near the vegetable aisle. I'm serious. And when my wife lovingly and diligently got me an appointment. I waited online in the vegetable aisle. True. And when I got there, I had to fill out some forms on a clipboard. They had a lot of clipboards, which they hand you with a number of forms. And when I got to my place online, they had my name written in a ruled school notebook with my cell phone number next to it. And when I came in for my shot, they crossed my name out. That is the high-tech information system that was used for Gil to get his vaccine both times, first and second vaccine. So that's pretty kind of third world, I guess. So, I mean, you're making a quantum leap to using information systems to get information and prepare for a patient's visit when we're dealing with ballpoint pens and clipboards. You're talking about sort of like it's very futuristic to me, Scott. Very futuristic. I feel like we're like in Doctor Who conversation now. So let me share some things that could happen. One, we need to actually, through your companies and others, really start to build encrypted email systems that doctors can use comfortably with confidence that if they're using the system, and heaven forbid the system is breached, they're not held liable personally for that breach. Someone has to indemnify them. That's part of it. Tort law
Tort reform.
tort reform has to get into the conversation here. Doctors feel like, so I did have the example, my mother-in-law, who is 89, needed to see her doctor. And there was a number of forms they needed her to fill out. She's 89, it's COVID. They said, does she have a fax machine where we can fax the forms to her? She could fill out beforehand.
I can't remember the last fax machine I saw.
Yeah, I got rid of my fax machine maybe 15 years ago. I had one. I most certainly had one, but I use PDFs and scan documents. My iPhone, there's under notes, you can scan documents, by the way. It's miraculous. No, we can't do scanning. Like my wife said, how about I pick up the forms, my mother-in-law fills them in, I scan them and send them to you. Can't do that. Can't do that. So there's some basics that we have to deal with. We have to improve our tolerance for risk. And certainly if COVID taught us anything, we have to look at risk. The risk of putting someone in contact with other people versus the risk of a HIPAA breach. I would say the risk of someone who's 89 being in contact with people is far riskier than the HIPAA breach, but yet the system insists on the HIPAA protection. What's HIPAA for? Is it for my mother-in-law or is it for the system? It's for the system. So Scott, we have the ability right now to use encrypted email. I'm sure your system has it in place for clients, other systems. We have the ability right now to use encrypted email to send the forms to the person and for them to send it back before the visit. And actually, just a joke, how many times have you gone to see the same doctor and each time you go, they give you the clipboard? Every 6 months, there's the clipboard. What happened to the information from the last clipboard?
Or this is even better. You get the clipboard, you go in, you finally get in to see your provider, and then your provider, looking at a screen, starts asking you all the questions that the piece of paper on the clipboard already asked you. I mean,
Well, that's a really important um, sort of situation, Jeff Steva, because you know why? We're our own health historians now. Think about it. We don't have usable, interoperable electronic medical records. From your urologist to your cardiologist, unless they're in the same system and you're using an EMR for that system, this doctor has no idea what this doctor is doing. They rely totally on your knowledge of what's going on, what medications you're taking, what you think is important. They rely on you. You're the historian of your life. Now you have to own your life. I got that. But is that right? Is information working for you? Is technology working for you? I don't think so. And that's what we're talking about here, Scott. We're talking about creating a system where information is democratized for the well-being of our people, of our society. And if I think of your last guest, Stacy Hurd, on this program, who's like she's one of my heroes, a role model. And I would say that Stacy, who is trained on how the health system works, she has 2 master's degrees dealing with the health system, has both been a stage 4 colon cancer survivor, and she's caring for a child with severe developmental disabilities as the child's primary caregiver. She's accessing the system. She had to access it actively for herself. Now, thank God, it's a follow-up, and she has to access the system every single day to help her son. The system's not working for her or her family. She has to battle the system. We have to make the system realize the citizens of this nation, the consumers, are the customer. It's not inviting the customer, the patient, to the table. It's their table. The table was always theirs. We have to actually see us as a full partner in the system. And that's what technology has to do for us. People are, by the way, putting some great things about what their companies are doing. I love this stuff, and I hope that when we share the video, these chat moments will remain, because these are great suggestions. I want to thank the audience for weighing in and offering their suggestions as well.
No, they're fantastic. A few I know personally, and we will get to these. For the better part of this first portion of the meeting, we've been talking about the system, the delivery mechanism, and how the system ultimately is not serving the patient, dollar first versus patient first. But I want to kind of flip the tables now, and because I look at healthcare as a reciprocal relationship, patient and provider, and providers get hamstrung by the system all the time. And I'm sure there's dozens on this meeting today that could speak to very personal situations to them. But the other way, patients getting actively involved in their own care. I think the pandemic has brought it to the forefront that patients need to be more actively involved in the active treatment of their lives versus the reactive treatment. And I think that virtual health has kind of kicked the barn doors open, if you will, on just how important this is, and trying to actively engage with their providers versus waiting until they're sick. Now, Gil, I know where you stand, that disparity in healthcare also plays a role in that activity, but let's just talk about the virtual health component first, and then we can talk a little bit about demographics and healthcare disparity versus access.
I'd love to. Thank you, Scott, for that. Look, the challenges in all of this. First of all, I just want to make a caveat. I really believe health providers are dedicated toward the well-being of their patients. I think health providers do put their patients first. I don't think it's about the money. I think they get into health for the right reason. I think they remain in health in the right reason, but still health providers have to navigate the system, right? They have to earn a living, they have to survive, and they have to feed their families as well. They go into medicine though for all the right reasons. And I was speaking this week last week to the chief medical officer of Ernst and Young, Yale Atulo, and he talked about in Nigeria, growing up and seeing someone die in a hospital, swearing that he would want to prevent that. And he became a great cardiologist. Today he's advising companies all around the world. So the spirit of these individuals is there. But we all agree to that.
Absolutely.
I think we all agree that the system is a force unto itself. It is like gravity. So the health system, the health ecosystem has its own gravity. Doctors, nurses, pharmacists, the allied health professionals, occupational therapists, physical therapists, respiratory therapists, radiologists, the technicians, all of that, they have to coexist within that gravitational force. And that to some extent is a culture unto itself. Now we're talking about the access of people with health concerns, patients, becoming greater advocates for themselves and using technology to do that. I'd like to believe that COVID is an inflection point, like almost like not a sharp turn to in a new direction, but I think it's a heightened awareness that we need to be more conscious of health. We need to be more conscious of maintaining health, and we need to be more conscious of advocating for our health. So there's different ways I think we need to understand how to do that. My data show me that most people do not understand what their health insurance company provides or doesn't provide. Most people don't understand how to appeal the system. When your insurer says no, how do you go back into the system and say, I don't accept no, and here's why, and rally the system to you? So I actually do think that the physician or the health professional and patient advocacy organizations need to do a better job on access to care. There are a number of great groups that are developing right now that are dedicating themselves actually to patient access to care. One in California, I think it's called the National Patient Access Coalition or Forum, there's all sorts of groups like that. These groups are really important, and I think will have greater importance. I think that patients need to express their desire to use technologies, their desire to be more connected to their health provider, and ask their physicians about, could I use this technology to be more connected to you? Would you be able to engage me? That's an important question, but probably one of the most important, among the more important questions or aspects of learning that we have is how to navigate the health system, how to stay healthy. I don't know if you had a course on that in high school or college, like health, what's healthy eating, what happens if you don't have healthy eating? I don't remember one. I mean, I'm a little older, keep in mind, a lot older, but I don't remember a course that sort of said, okay, we're going to spend like a semester talking about staying alive. And that doesn't exist. And so our system is based on sick care. The whole system is based upon you're in this state of not sick and then sick. And when you're sick, you'll access the system at your most expensive moment. Maybe if we marshaled our resources on the corporate level, the health insurance level, the provider level, the policy level, the consumer advocacy level, and said, how do we work to make you healthier, keep you healthier, work on preventive care? Maybe, first of all, these technologies would become fused into that, and actually we wouldn't be spending $3.7 trillion on health. The other question, though, you kind of raised is disparities. It's really tough to do that when you have in Texas minimum wage of under $8 an hour, and you are working, you're on Medicaid most likely because you have reached that poverty threshold, and you have a child or two at home. What are you going to feed that family? You're going to feed them fast food. You're going to feed them carbohydrates. Vegetables are becoming more expensive. You're going to use more processed foods. That's going to actually wean a generation of Americans, as prepare them to be pre-diabetic, set them up for heart disease. And actually, there are 11 cancers that are associated with obesity. So what are we doing to ourselves as a nation? We're setting ourselves up. We claim that obesity is an epidemic in this country. Well, I'll do us one better. It is an epidemic in this country. That's the tip of the iceberg. And in COVID, when we start to go back to see our doctors, I think we're going to see a lot of undiagnosed cancers, a lot of undiagnosed heart disease, a lot of undiagnosed diabetes. These are called non-communicable diseases. And I would say, Scott, one of the reasons I'm using an Apple Watch 6, and I'm fortunate to be able to afford one, I want to acknowledge that, I feel very blessed, is I am using it, I am using my app and the data to check my diet and so forth. During COVID, you've heard of the COVID-19, which refers to the freshman 15, weight gain. I've actually gone the COVID minus 19. I've lost 19 pounds during COVID by design. But it's hard to do that when you're being paid minimum wage. Who's being paid minimum wage in a disproportionate way, sort of disproportionately? I think we could agree people of color are most at risk in this nation. And therefore, for the same reason they are most at risk for mortality from COVID, they're most at risk for obesity, they're most at risk for diabetes, they're most at risk for heart disease. And it's not predisposed, as we used to say clinically, it's not correct. They're environmentally predisposed. Why? Starts with racism. Racism leads to despair. Despair leads to disease. Disease leads to death. We're creating the very system we want to avoid. I think that technology and information is part of the solution.
I mean, we talk about patient education though, and how when you're confronted with only one choice, how does education help? Where do we go with education to really turn the tide? Because as I understand COVID-19 and what other variants we will all in all likelihood see, the basic design and the way in which COVID attacks the body exacerbates the same conditions you've talked about. So individuals who may be in their late 20s, early 30s, maybe early signs of cardiovascular, pre-diabetic, that's going to be accelerated quite quickly to where in all likelihood, the body's going to be responding like they're in their late 40s to these same diseases. So education, where do we go with it? How do we take that and then get proper healthcare delivery out to them?
So this is what I mentioned before. We have 51 health systems. I do think that our policy leaders, state by state and federal, need to understand that the health of this nation is their responsibility. It's our responsibility too, as individual households and consumers. OSP is doing a great job in contributing to the conversation, and these conversations are part of that. So thank you for that. But I do think that we need to understand that health, or mindfulness and behavioral health, is not separate from policy. It's not separate from mindfulness and action. And so the information that you and your colleagues are generating, actually, I hope that you will continue your organization's advocacy and basically say, look, as an information platform, as an organization that is connecting disparate systems, we think that there need to be some unifiers here. So I do think it's got to start somewhere. And where it starts with is awareness. Information, the aggregated, actually starts to create that awareness. And I think that everybody listening in to the call and seeing the video needs to understand that we're each part of the solution. We're each also part of the problem. We've got to unite. I understand we have different points of view. We have to look at the prize. The prize is a healthier nation, a more connected nation. When we have healthier people, we actually have people who have the sustenance and economic well-being to take care of their households. And I think that technology has a role to play in that. And I really have to say, I cannot thank you enough for inviting me to this conversation today, and bringing in everybody in such an inclusive way. I want to thank you for that.
Absolutely. If you're okay with that, I know we have a couple of more topics to get through, but there's a few pertinent questions, if it's okay, I want to address first. Earlier, you named an organization for decentralized trials. Somebody was asking, could you just give the name of that
Yes,
organization again?
it's called dtra.org. dtra.org. It's an organization of corporations and regulatory groups and patient groups who've joined. It costs money to join. These groups are involved in working groups to solve some of the biggest challenges that technology and life science industry face to accelerate drug development and make it more inclusive.
Thank you. I know Kenneth had a question regarding health information exchanges. One second while I get it up here. How can we leverage health information exchanges to make clinicians and patients use them effectively? They were originally designed to make the exchange of patient information effective, but we can, I think, safely admit that in some instances that's not happening.
Yeah. So, look, a lot of the information exchange, unfortunately, is regulated by law. That's a big challenge. That's a big challenge. There's nothing more I can say to that, but we need to make the laws work for the consumer, for the patient. And we need to center these laws around their needs. That is exactly why HIPAA was created. It wasn't created for the system. Initially, it was to protect patient confidentiality and privacy, but it's morphed into its own universe. We need to revisit that. Now, our previous administration, the Secretary of HHS promised that by 2020 faxes would be phased out. That didn't happen. Didn't happen. So it's a hard challenge. I don't blame her for not accomplishing that. The system is a behemoth. We've got to make it work for us. And I think that this is where people have to check in a little bit.
Thank you, Gil. And I agree. It's certain areas we've advanced in healthcare as well. Certain key critical areas have remained in stasis, unfortunately. And it's those areas of stasis that I think are prohibiting us from leaping forward. I mean, it's funny how many times the word fax has come up in one conversation when I don't think I've used it in 2 years before today.
Yeah,
So
it's just the way of the world. I know we're wrapping up now, Scott. I just want to say that I welcome. I know this is going to post. I know OSP post these conversations. I urge people to reach out to me. You can reach out to me on LinkedIn. You can reach out to me on Twitter. I use my name on both those formats. It's on Twitter. It's Gil_Bashe, Bashe. I welcome you to follow me. All I do is health stuff. I'm not a sports person. I'm a health nerd. So you'll get health information on my Twitter feed. LinkedIn is the same. And so I welcome people's conversation. I've seen a lot in the chat, so I welcome people reaching out.
thanks, Gil. Let's see here. Rachel's asking, independent care providers in hospice settings also encourage patients to communicate their opinions freely through digital health apps. She's asking, would this be a pro or a con for care providers?
So this is really critical. It's a call unto itself. Population health management is really what we're talking about, and technology-enabled population health management. So when we take a look at people leaving medical institutions, hospitals, they've had open heart surgery, they've had hip replacement surgery, they've had COVID, and they're moving into step down care centers. It should not be hoteling. It should not be hoteling. It really has to be care enabled settings. Technology has a huge role to play there. Huge role to play there.
Thanks. Harry Minter, patients are the main focus of healthcare and digital health innovations. How can digital health help with providing real-time health access to patients in remote locations?
Well, it's a given, right? I mean, the ability of telehealth to connect people, of smart technology, wireless technology, that's a given, and clinical trials. Remote technologies have to be widely deployed. They exist, they're proven, they're reviewed by the Food and Drug Administration. Two challenges: security, right? The concern about data security, encryption, and reimbursement. If we can solve those two challenges, watch improvement of access to care made possible. In many cases, we have areas also of economic challenge, and they often don't have expert medical institutions next to them. I was going through different hospitals in Brooklyn, New York recently, and you can see the hospital in one part of the community is really a high-end hospital. Another part is really dealing predominantly with a Medicaid population. They deserve quality care. Technology can improve that as well.
And I think that's going to be the next great solve, and I think it's going to come sooner than later, Gil, as you've taken a look at the massive consolidation of acute care organizations, buying up other hospitals, consolidating their abilities to leverage clinical labor. The rural markets are becoming more and more underserved. And I am wondering whether or not telehealth becomes the ultimate solve there, by enabling providers to access rural markets that are either losing facilities, losing providers, because anybody who's in healthcare understands we are in a shortage of nurses, a shortage of providers, a shortage of mid-levels. And all of that is creating strain on the rural market. So I'm hopeful that both digital health technology improves communication as well as access for the rural markets.
Amen. You could not have said it better. We've got a lot of great things going on. We've got a lot to improve. There's no doubt about it. We have the capacity, we have the ideas, we have the innovation, we have the will. We have to create the system and process in place to make it happen. I think you said that quite well, Scott.
So, Gil, I think we've touched on a lot of and very expansive topics. I mean, I know we were a little more organized, but things just generally flowed, and we covered a lot today. For you, and as you go about doing what you do to improve the human condition, what would be your biggest takeaway and leave for both OSP as well as for our attendees today?
That's a great wrap-up question. And Scott, first of all, again, thank you personally and your colleagues, you and your colleagues at OSP. Continue to do the great job you're doing. I'm going to say it is not so much knowledge, persistence, courage, boldness. It's about a mindset of possibility. And that's what made the COVID vaccines possible. It proved the fact that we're capable of everything we need to set our mind to, whether it's improving the environment or sustaining human life. We can do it. Three things. Collaboration is one. Listening to each other, two. And understanding that the system was created for us, not for its own sake. Those three things I would wrap up and say, keep in mind. Scott, again, I want to thank you and the listeners so much. I hope we have an opportunity to do this again.
Thank you very much, Gil. Appreciate you sharing your viewpoints. I hope all of you attendees found this beneficial today. Please feel free to visit osplabs.com to learn more about our healthcare industry, as well as discover our helpful bonus content. And right now, everyone, please stay tuned, stay well, stay safe. Thank you, Gil.
Thank you. Thank you all. Bye-bye.
Cheers.